Hello, my name is Claudia Villatoro, and I'm a second-year internal medicine resident at Ascension St. John Hospital, and I'll be talking about Tocilizumab, a retrospective multi-center cohort study of critically ill patients with COVID-19. We start with the schematic representation of the cytokine storm. We have here triggers including COVID-19 that lead to activation of T cells, inadequate negative regulation, and immune hyperactivation that leads to pathological levels of the cytokines, prolonged activation of signaling pathways that results in systemic inflammation and organ damage, and ultimately multi-organ failure and death. IL-6 is one of the cytokines in Tocilizumab. An IL-6 receptor blocker was proposed as a treatment for COVID-19 to ultimately prevent death. Initial uncontrolled studies. This is a study by Xu et al. Among 21 Chinese adults treated with Tocilizumab that found that CRP levels, temperature, and percent of inhaled oxygen decreased over time, whereas oxygen saturation improved over time. Here we have initial retrospective studies, one by Summers et al., that found that Tocilizumab treatment resulted in a higher probability of survival when compared to those who were not treated. Another study by Guaraldi et al. Found some similar results. Tocilizumab resulted in a lower probability of mechanical ventilation and death when compared to standard therapy, and there was no difference between subcutaneous or intravenous route. And similarly, when looking at death, Tocilizumab resulted in improved survival probability. So with this in mind, our research question was, what is the effect of Tocilizumab treatment for critically ill patients with COVID-19 pneumonia in several hospitals in the southeast area of Michigan? We conducted a retrospective cohort study of critically ill adults admitted to the ICU between March 15 and May 8th to the southeast area of Michigan hospitals. Diagnosis was done with a PCR test of a nasopharyngeal swab, and we excluded children and adults not admitted to the ICU for COVID-19 pneumonia, and data was collected by electronic medical record review. Tocilizumab treatment was our main exposure. It was initially allocated using the H score, but later the final decision was done by the infectious disease specialist. The standard dose was 8 milligrams per kilogram at a maximum dose of 400 milligrams IV once. The primary outcome of interest was mortality. We defined case fatality rate as the number of deaths divided by the number of patients assessed after ICU admissions. The secondary outcomes were ICU length of stay and secondary infections. For our data analysis, we conducted univariable analysis with student t-test or Mann-Whitney for continuous variables, chi-square tests for categorical, and trend tests for ordinal variables. Our multivariable analysis, we conducted Cox regression models to assess the effect of Tocilizumab on mortality. Time to event was defined as days from admission to death or discharge. We used stepwise figure regression to build the final model and introduce the potential confounders based on univariable analysis. This is our demographic characteristics. We had a total of 154 patients, 34 received Tocilizumab. Compared to the non-treated, the treated group was significantly younger. As you can see here, there was no differences in gender and predominantly African American. The treated had higher prevalence of obesity, longer duration of symptoms before hospitalization, fewer comorbidities as reflected by a lower median Charlson comorbidity index, lower creatinine and procalcitonin levels, and higher ALT levels on admission. Notably, most of our population received hydroxychloroquine and corticosteroids without difference between treatment groups, and the treatment in the context of critical illness like renal replacement therapy, prone positioning, and APRV were more likely to happen in the treated group, and this was a statistically significant difference. Our case fatality rate was 71% overall, and the treated group had a significantly lower case fatality rate. Here we have cumulative survival curves stratified by Tocilizumab treatment, adjusted for age, multiple comorbidities, and septic shock, and we can see Tocilizumab resulted in a lower probability of mortality with a hazard ratio of 0.47 and a p-value of 0.009. To assess the difference on supportive therapies in the context of ventilatory support like APRV and proning between treatment groups, we excluded all patients that were not intubated and reran the Cox regression model using the same stepwise regression technique. This second model was adjusted for age, comorbidity, septic shock, and elevated creatinine. We found an attenuation of the association with a hazard ratio of 0.52, but it remains statistically significant. Our secondary infections rate was higher in the treatment group, but there was no statistically significant difference. ICU length of stay was significantly longer in the treatment group, and this difference was statistically significant. For our discussion, our results are consistent with previous similar studies. Length of stay was significantly longer for treated patients, reflecting higher survival. Moreover, the rate of secondary infections was higher in the tocilizumab group, which could have resulted in longer length of stay. We had a significant higher case fatality rate since we conducted our study during the first wave, and this can highlight that tocilizumab treatment can be most beneficial for the sickest. Our strengths: we have an understudied population, mostly African Americans, high rates of obesity, and our results are consistent with prior studies. Limitations: our data was observational, therefore residual confounding is always a possibility. We also had heterogeneity in supportive therapies in the context of critical illness, but we addressed this by rerunning the model in only mechanical ventilated patients as previously stated. In conclusion, tocilizumab treatment for critically ill patients with COVID-19 resulted in a lower likelihood of mortality. Thank you.